Well, greetings everyone, and welcome to the ECG case for the week of October 28th, 2013. And this week's case was a pre-hospital case that was brought into our emergency department not too long ago. It's a 52-year-old man that complains of chest pain. He's brought in by ambulance. Paramedics sent this EKG ahead of time. Now, we're a center that oftentimes they will transmit EKGs to, and based on the 12-lead EKG, we can decide whether to activate the cath lab or not. And this was clearly a concerning EKG. Take a look. There's ST segment elevation in some of the leads, maybe a little bit of ST segment elevation there as well, and AVR, ST segment elevation there. That's concerning. We've talked about that before. There's ST segment depression in 2 and in I missed that. AVL lead 1 and maybe some ST segment depression out there. There's also T-wave inversions in a bunch of leads. There's a whole heck of a lot of abnormalities here that ought to be making us think of cardiac ischemia and maybe activating the cath lab, right? Well, the 12-lead EKG showed something a little bit different. The 12-lead EKG showed actually, the interpretation just showed LVH with some secondary repolarization abnormality or strain type of pattern, but maybe a little hypertrophy and some ischemic pattern as well. So what are you going to do with that? Are you going to activate the cath lab based on that? Well, this is a tough call. Now, in the past, I've always said that I'll never show you an EKG interpretation unless it's wrong. But in this case, I have to tell you that the EKG interpretation was correct. Actually, it was a bit of a hedge because it said LVH and it also said maybe ischemia. So, the EKG interpretation is completely useless. So what do you do? Well, there's a handful of things that you need to know about LVH which might allow you to call the patient's EKG a strain pattern. So let's talk about left ventricular hypertrophy. Let me precede this by saying, although I love electrocardiography, I hate LVH. I absolutely hate LVH. If LVH were a baby, this is a baby that even his mama would hate. I mean, LVH, I don't think anybody likes LVH because the EKG criteria are so difficult. First of all, the EKG is not even all that sensitive for picking up LVH. It's only about 50% sensitive. It's pretty specific, but the sensitivity for the EKG or ECG to pick up LVH is not all that good. The real diagnosis is based on echo or cath. But the problem is that when somebody has left ventricular hypertrophy, the EKG can look a whole heck of a lot like a true STEMI. And in fact, probably the most common misdiagnosis over and undercall of STEMI is because of LVH. So you need to know the criteria for LVH. And then we're going to go through those criteria here. It's a painful thing, but also I mentioned there's a lot of different criteria that people have put forth. These are the criteria that I like to remember because they're relatively simple. Take the R wave in V5 or 6, plus the S wave in V1, take whichever is bigger between V5 and V6, and add it to the S wave in V1. If it's greater than 35 millimeters, call it LVH. Most people know that. You can also take the maximum R and the maximum S in any precordial lead. If they add up to more than 45, that works. And also, probably the most specific criteria, as I recall, is if the R wave all by itself in AVL is greater than 11 millimeters, you're done. That is LVH. Now, LVH can produce some repolarization abnormalities, or what I like to refer to as a strain pattern. Many other people use that term as well. And LVH can produce ST segment depression in the lateral leads, but also in 2 and AVF. It can produce inverted T waves in those same leads. It can produce ST elevation in the right precordial leads and AVR, and also can produce QRS widening. Now, with the exception of the QRS widening, this is a tough call because all of these make you think of cardiac ischemia. There's one clue that may be helpful. The inverted T waves with LVH are usually a bit asymmetric, okay? True ischemia tends to be more symmetric in appearance. So this would be true ischemia. That's concerning, whereas this is LVH. It tends to be a bit more asymmetric. So let's take a look at some more examples here of LVH. All right, take a look at this. This is a tough one. There's flip T waves and ST segment depression in a whole bunch of leads. This one has it in all 3 inferior leads, and V4, it looks like the patient's asystolic in V4, but there's some artifact out here. But there's ST segment elevation in the right precordial leads. This is a mess that I'm making with my drawing tool, but that's because the EKG is a mess. LVH, I hate it. That's why I hate it so much. Okay, here's LVH with strain also. Take a look at these T waves. They're just a little bit asymmetric. They're pretty god-awful looking. They're concerning. There's a little bit of ST elevation in V1, little bit of ST elevation in AVL. There's flipped T waves in 1, 2, and AVF, okay? And also in AVL. These are all lateral leads, okay? Remember, 1 and AVL are lateral leads. Lead 2 is kind of a lateral lead as well. And so you can get flipped T waves and ST depression in lead 2. And in fact, in lead AVF, if it's really bad, you can get the same findings in AVF as well. All right, here's another one. Forget the rhythm here. This patient has an abnormal rhythm, but take a look. The patient has flipped T waves and maybe a little ST depression in 1 in AVL, as well as in in V5 and V6. That would be clearly concerning. You also appreciate the nice asymmetric ST segment or T wave inversions out there. Here's another example. Once again, forget the rhythm. Just take a look at the 12 leads. There's ST elevation out there, so you wonder, is this a septal STEMI? And in this case, the lateral leads out here look okay, but 1 in AVL show flipped T waves and ST segment depression. That's a tough call. Here's another 12 lead. And this actually resulted in activation of the cath lab, which turned out to be a false negative cath, clean coronaries. But it looks like there's a septal STEMI. There's flipped T waves. There's some flipped T waves and ST depression out laterally. So it would be very easy to call this a septal STEMI with lateral reciprocal changes. This turned out to be purely LVH with strain. When in doubt, don't hesitate to call cardiology with these type of cases. All right. So this is a really difficult diagnosis to make. There should be no doubt about that. Now, take a look at this. Okay. In this particular case, the patient has LVH. The R wave in AVL is greater than 11. And there's flipped T waves in 1 in AVL, but these flipped T waves, you'll notice, they tend to be more symmetric in appearance, okay? I don't know if my drawing is helping or making things worse, but take a look at how symmetric those T waves are. Those are not typical for strain flipped T waves. This patient actually had LVH, but this patient did have a bump in troponins and had lateral wall ischemia, which resolved with treatment. All right. So, and for comparison, these are the nice asymmetric T waves. Again, asymmetric T waves that look like this, that is LVH with strain. But if you get T waves that are really nice and symmetric, that would make you worry. So symmetric T waves, you got to worry more. Asymmetric T waves tend more often to be associated with just an LVH strain type of pattern. Take a look at this EKG now as well. Okay. These are asymmetric. These are nice LVH type of flipped T waves, okay? But take a look, and also ST depression. But if you look down here in the inferior leads, you'll notice that the ST depression is not associated with asymmetric T waves. In fact, the ST depression is very horizontal, okay? Very horizontal, in contrast to the downsloping type of ST depression. When you see ST depression, which is horizontal in appearance, do not call that strain. ST depression, which is horizontal, is bad. ST depression that is downsloping and oblique, that's not good, but that's probably more likely the LVH type of pattern. But when you see horizontal ST segment depression, do not attribute that to a strain pattern, and that patient turned out to have cardiac ischemia. All right. When in doubt, the other thing to do, get serial EKGs and get old EKGs. Take a look and see whether this patient has in the past had a strain pattern. And if you don't have old EKGs, you can do serial EKGs and see if anything's evolving, which would point towards true cardiac ischemia. All right. So again, this is a tough call, LVH versus true cardiac ischemia. And then complicating things further, people with LVH and strain can develop cardiac ischemia on top of that. There's some clues that can help. Look for symmetry of the T wave inversions. Get old EKGs. Get serial EKGs. But the key thing is that before you even start considering LVH with strain, you've got to know what those LVH criteria are. And so review those criteria once again. This is really important. Every emergency physician has to know what the criteria are for LVH. So when you have a patient coming in with concerning symptoms and you see that there's LVH present, best thing to do, get old EKGs, get serial EKGs, get on the phone with cardiology, get them to weigh in as well. But if you see horizontal ST depression or symmetric T waves, you cannot simply attribute that to just LVH with strain. So there's a couple clues. I realize that what I've told you on this podcast is not completely definitive. I haven't given you any clues that can definitely guarantee that you're looking at LVH and strain and not cardiac ischemia. There are some clues that clearly weigh in favor of cardiac ischemia, but can you rule out cardiac ischemia? The answer is no. But all I can say is that you've got to look at a lot of EKGs, get practice, get to know the criteria for LVH, and with practice, you'll get better at it. And when in doubt, when you're looking at LVH and strain and you're wondering whether there's also concurrent ischemia, get on the phone with cardiology, get them involved as well. You know, I hate this podcast. I hate this videocast because I'm not giving you any definitive clues. But the bottom line is LVH is a tough diagnosis. It's the most commonly overcalled or most common reason for overcall and undercall of true STEMI. And all you can do is practice these cases, practice. Take a look at a lot of LVH cases. You'll get better at it and know the criteria. Well, I hope that was helpful, and I look forward to talking to you next week. Bye for now.